Okay, we are on time. Hi, everyone. Welcome to the UNC Water and Health Conference. And this session, thank you for joining us. My name is Hania Zaneib. I am representing the UNC Water Institute and will be your room host today. Before we get started on our presentations, I have a couple of announcements. See, I see slides moving. So just a quick plug about our networking and sponsor events. We do have events in the afternoons at Remo. So interested folks should make sure to go join those sessions. And another reminder of the late early show. This is especially applicable if you have missed any of the sessions during the day, as it will include a recap of the day's events, and the times for the late early show are right here. It's 10 o'clock Eastern Standard Time if you're in the United States. And then another reminder that all chats to the presenters or questions should go in Potable in the chat box there. The chat in Zoom has been disabled for the participants. And, oh, sorry, I think I missed that one. And a thank you to our sponsors today, which is RTI, Tetra Tech, and NSF. With that, I'll introduce our speakers. We have Dr. Catherine Alfredo joining us today from the University of South Florida, and Dr. Monica Lee from Johns Hopkins Bloomberg School of Public Health, and last but not least, Maureen Ricau from Tufts University. So our first speaker of the day is going to be Maureen. I will stop screen share and we're good to go, Maureen, to share your screen and begin.
Hi, everybody. My name is Maureen Ricau. I'm a PhD student at Tufts University. So today I'm going to present you the results from the evaluation of monitoring tools for WASH response in a cholera outbreak in Northeast Nigeria. So cholera is endemic in Nigeria, and some of the enabling conditions are conflict, displacement of population, which leads to disruption of water and sanitation services. And so the WASH cluster partners in Northeast Nigeria are responding to cholera in IDP camps and host communities with WASH programs. So as the lead of the Cholera Technical Working Group, Cholera Twig in Borno State, Solidarité Internationale developed a WASH in cholera response monitoring tools. And so the objective of this study was to review these tools to understand and improve WASH in cholera monitoring in Northeast Nigeria, but also to inform WASH in cholera response monitoring globally. So first, we collected data through the COBO toolbox. These data were collected by the organizations that are members of the Cholera Twig. There were 3 different COBO form questionnaires that were available. One that reported household disinfection activities, a second one that reported water chlorination activities, and a third one that reported multiple WASH activities. These 3 databases from these 3 forms were aggregated together in one database, and the data was cleaned. So we corrected typos and harmonized the names of the places and WASH activities. And also we separated, when multiple WASH activities were reported together in one form, we separated the activities into different data entry points. And then the merged database was stratified and analyzed by implementing organization, WASH activities, month and day, and local government area. We also did key informant interviews with the members of the Twig. We used a semi-structured KI guide to understand the successes, the challenges, and the barriers to using the monitoring tools, and also to collect recommendations for how the tools could be improved. So the guide included sections on cholera-related interventions in Borno State, also a section on monitoring and evaluation activities, monitoring tool use, and some recommendations for improvements. We did inductive qualitative content analysis, and so the interview segments were coded into themes that emerged during the analysis through NVivo. So some results. For the data analysis, there were 723 forms that were collected from July to December 2019. It resulted in 980 single entry activities reported. There were 14 organizations that implemented WASH activities and that reported on the tool. And the activities were implemented in 14 LGAs. For the key informant interviews, we did 7 of them with monitoring tool users and also the persons that were decision makers on the use of the tool. They came from 6 different organizations, and there were 8 themes that emerged from the KII. So overall, 34% of the total activities were reported by one organization. This may be explained because it was a requirement from their donor. 4 organizations reported less than 1% of the activities. The activities that was the most reported was water activities with more than 40%, then followed by hygiene promotion activities with more than 30%. And the other activities were far less reported. The third one was sanitation activities with about 10% of total activities. And there were very few spraying and disinfection activities and few reports of active case findings. Also, most organizations implemented multiple activities, and hygiene promotion was implemented by all organizations. More than 50% of the activities were reported in September, and most organizations reported mainly over 1 month. And so there is no regular reporting throughout the period. We can see that no organization actually reported every month of the period. The forms were collected irregularly throughout the week. And so some days there are 0 forms collected, and it can go up to more than 100 forms collected in 1 day. Also, we see that the number of activities that is reported is heavily influenced by the organizations that reported a lot of their activities over certain months or certain LGAs. For the key informant interviews, 8 themes emerged. So for reporting processes, half of the informants reported daily and the other half weekly. Some of them reported 1 activity per form, while others reported all activities of the week in 1 form. So there were some discrepancies here. Also, informants indicated that having multiple forms to fill was confusing. On training, the training was conducted during a cholera tweak meeting, and then the participants trained their own teams that were collecting the data. But despite receiving this training, there were still some questions and processes that were unclear. For data access and use, informants indicated that they had access to the dashboard that with the consolidated data during the cholera tweak meetings, but not to the database with the raw data. Most informants reported that they were using the data from the platform to guide their programming. And the 2 positive aspects that were the most mentioned were the simplicity of using the monitoring tools and the improved reporting that resulted from it. It helped identify cholera hotspots and response gaps. So the differences in frequency of reporting, some reporting daily, other weekly, and the confusion on which one to complete or how to report the activities, it shows unclear and non-harmonized data collection process. but the data was still used to identify response gaps and to adapt programming accordingly. The tools resulted in an improved monitoring thanks to its ease of use. And so overall, the monitoring tools helped reduce response gaps and improve coverage. The organizations were able to adjust their implementation strategy and coordinate with the other twig members, but the lack of data and irregularity of reporting over time, as well as the multiple data collection processes, led to inconsistent data collection. So it was difficult to study collectively and consistently this data. The monitoring tools data could not be used to assess the overall sector preparedness and effectiveness of the cholera response, or to improve the implementation of the intervention. So some of the recommendations to improve the tool were to increase the quantity of data reported. Some solution could be to support the organizations that have less experience on monitoring activities and less experience with using COBO tools. Also reporting could be made a grant requirement. To ensure data consistency, some solutions could be to have clear and close answer questions with a fixed choice list of answers, and also to have regular refresher trainings for the data collectors on the reporting process and on the questionnaire. And to improve data relevancy, the purpose of the data collection has to be clearly defined, and only questions with information that is going to be used and analyzed should be included. Thank you for listening. If you have any questions, I'm here to answer them.
Thank you, Maureen. I will be keeping an eye out on the chat page in Potable, so all questions should be directed there. While we wait for questions, I actually had one for you. In a couple of slides in the beginning, you mentioned that one of the activities they had reported was water activities. I was wondering if there was a little bit more, like if you could expand a bit more on what those meant.
Yeah, it was mainly chlorination of water points.
Got it. Yeah.
And a little bit of them were also rehabilitation, construction of water points, but it was mainly chlorination.
That's helpful. You mentioned that trainings should be increased for these organizations and having the data reported and data organized. Do you think that's the only challenge that they've been facing, like the only barrier that they haven't been trained, or do you think there's another something going on and that we don't know of that could be like a barrier to why there hasn't been enough data reported?
Yeah, well, it's always the difficult thing is to get people to enter the data and everything. So to have kind of an incentive for the organizations to do it. But the training was to kind of solve the problem of having different data collection processes. So we understood that not everybody was using the tool in the same way and filling the forms in the same way. So having regular trainings, like one in the beginning is not enough. You have to do like every couple of months the training to just ensure that everybody has the same way of filling the forms, just to ensure consistency. But yeah, it might not be enough of an incentive for organizations to constantly fill the data.
Well, thank you. We do have one question from Joanne. She's asking, she said it's an interesting presentation, and what are you hoping to find with the study and who developed the tool?
Sorry, I didn't understand.
Oh, I can repeat it.
Yeah.
What were you hoping to find with the study and who developed the tool?
So yeah, the tool was developed by Solidarité Internationale in the first place as the cholera lead for the wash sector. And so they wanted to do it because they wanted to update the tool because they saw that the organizations were not constantly filling the information. And so that was the main purpose of the evaluation, is to kind of see how we could improve this, like how people could, like we could get more information, let's say. So to make it easier to use and kind of find incentives for the organizations to use this monitoring tool.
Thank you. Do you have a comment on why you think the 3 months where most data was reported, why they're the, like across organizations, why those 3 months are the ones where most organizations are keen to report data?
So it's probably when the cholera cases were the highest. So then there are more activities implemented. But what we saw also is that some days there were like a huge number of forms reported. So probably not directly related to the day they were actually implemented. And so maybe some organizations implemented activities over September and October, but reported all their activities in October. So we have kind of a
Yeah, that makes sense. Yes, it was probably practical. We have another question from Joanne again. She's asking, was the incidence of cholera logged and compared with tool inputs?
No, they were not. We didn't have access to the cholera cases, which was one of the drawbacks. We couldn't compare if the height, like the peak of activities, was because of higher cholera cases or not. And yeah, this is something like this kind of data should be compared with the number of cholera cases to also make more sense and conclude on their effectiveness.
Thank you. And that's all the time we have for this presentation. So I will move on and introduce the second speaker, who is Dr. Catherine Alfredo from the University of South Florida. And she will be presenting on identifying drivers of successful community-based water treatment. And all righty, we are set up to begin.
Great. So thank you.
Sorry, there we go. Sorry, we could only see part of your presentation.
You can see the whole thing now?
Yes.
Okay, great. Well, thank you very much. Yes, the talk that I'm giving today is identifying drivers of successful community-based water treatment. I'm based in rural areas of Yavatmal, India, and looking at fluoride treatment. I'd like to recognize my co-author on this, Dr. Tanya O'Gara, who's at Middlesex University and is in the Department of Economics. So where we are in India is we're in Maharashtra, which is in blue in that small square, and then in the Yavatmal district, which is on the eastern part of Maharashtra, or the poorer area of this state. In Yavatmal alone, 53 villages are 100% impacted by fluoride. That means that they have no other sources of water that are fluoride free. Now, if you have lots of fluoride or above the health limit of fluoride in your water, it can lead to issues like dental fluorosis and skeletal fluorosis. So the situation in these areas are that if you have a village that is impacted by fluoride, first the government comes in and says, well, can we just do some well switching or something? And if that's not possible, then they look to see, can we bring in piped water? And if that's not possible, then they build some of these rural drinking water treatment plants. And I'm focusing here on these electrocoagulation plants. They build these rural treatment plants. They have these 5-year contracts with companies who build and manage it for 5 years. And then at the end of the contract period, the company hands it over to the community to own and operate. And it's this handover process that we're really interested in looking at. And we wanted to identify the determinants of successful management of community-based water treatment systems at the point of handover, and specifically what factors influence success and how do they interact. So when we're defining success here, for us, we were really thinking about the technology working out into the future. So If we think about at this point 0, we have a total number of treatment plants that are installed. And then over time, you might have a loss of functionality, a loss of efficiency, and or a loss of access to the treatment plant. And those that are continue on are the ones that we're saying have continued success. Let me move my little square out of the way. It's covering half my screen. So when we define success here, we're talking about community-based water treatment systems, and we're talking about functionality. Can you turn it on and off? So did they pay their bills? Is there electricity? Can you turn it on and off? And then efficiency. Is the technology actually chemically achieving treatment and removal? And we considered when functionality and efficiency are sustained over time, then for this study, we were saying that water treatment could be considered sustainable. Now, when we're framing this out, we had a conceptual model that influenced success. And when we put this together, it became apparent we have 3 main areas. We have policy and governance that's overlaying the whole thing, that kind of drives it all. The social aspect, the community and the users who are using it, and then the technology itself. And all of these together are what makes something functional and efficient treatment. To investigate this, we looked at a variety of different things. We did contingent valuation surveys, lab and field experiments, which look at cooperative norms and cooperation within a community, technical analysis, looking at the fluoride technology and the water supply, interviews with the operators just to track functionality over time, and an in-depth case study. Now, for the data collection, it was between 2014 and 2017 that we collected all this data. And I'm just going to highlight 2 aspects of our methodologies. I would point you to our papers if you want to get a more in-depth feel for what our methods were. So one of the first things I want to talk about is just how we framed the contingent valuation survey. So we set up a hypothetical scenario and as part of this process to tell respondents or interviewees, imagine that a water committee could be set up in your village to run the water treatment system. For this to happen, everyone would have to make a contribution for operation and maintenance and assume that the water committee was fair, honest, and responsible. And then we asked, would you be willing to pay towards this? How much would you be willing to pay? Now, for the lab and field experiments, some of you might not be too familiar with this. For this, what we did is we brought 5 people into a room together, and we played basically games with real money. So we gave everybody a certain amount of money at the beginning of a round, and we said, how much are you willing to contribute to a group account? All the money that was contributed to a group account is then multiplied by 2 and then divided back out among participants. So if everybody contributed, everyone makes out with double the amount of money each round. If everyone but one person contributes, everyone ends up with more money, but that one person who didn't contribute actually ends up with the most money because they keep the money they didn't contribute and benefit from the group account. So this is a way to test cooperation around a common good. So let's dive right into results. So looking at the preferences for water treatment, we had 2 real big scenarios here. We asked them, would you be willing to pay some rupees per month towards the support of the treatment system? And would you be willing to pay some rupees per 20-liter container? So a willingness to pay per month and a willingness to pay per container scenarios. Now, this per container is actually really important because it's first appeared in India, this demand-driven way of charging for water in the early 2000s. And it's on the rise. When you talk to district level engineers, they were putting in water ATMs or wanted water ATMs in all these villages. So we thought it would be really important to test this per liter container. And it really is untested as a quasi-communal support scheme in this context. So when we look at what happened when we asked these and who responded, we see first that more people are willing to pay per month than per container. So 87% roughly of our respondents said, yes, I'd be willing to pay something per month, where only about half of the respondents would be willing to pay per container. We had more people protesting the per container construct than we did with the per monthly construct. So that's something that's really important we need to keep in mind as these water ATMs move forward. And then finally, for those who did contribute, for the willingness to pay per container scheme, people were willing to pay a higher percentage of the income. Now, this is something that we have to be careful with because it could mean that you could have elite capture, or those who are willing to afford more, willing to pay more. But it did seem that those who were committed to the willingness to pay per container scheme were willing to pay a lot towards it. When we ran our regression analysis on these results and looked at some of the drivers for the willingness to pay, some things that were obvious, like income drove it. Other things like born in the village, fluoride is an accumulated, fluorosis is an accumulated response to fluoride exposure. So being born in the village was really important. And the other thing that was really important is belief that the handover is going to be successful. Now, when we look at cooperation across the villages and we look at our base rounds of these cooperation games before we did interventions, we really saw no difference between the villages during the base rounds. And I'll go back to this when we look a little bit more at the results. So when we examine success, so was any of this successful? We can say, were they functional at the end of basically 2 years? And then what were the reasons and how long were they functional? So the village on top, Malvira, was the only one that was still functional 2 years after we started this study. And what's also really important is that it wasn't functional the entire period. 3 of them weren't functional the entire working period, which meant that they had an issue, solved it, overcame it, and it ran again, even for those that failed later on. So if we take Malvira as a success story and we say, well, are these villages significantly different in the terms of willingness to pay? We do see that some villages are statistically significantly different, those with the M on top of those bars. However, they were willing to pay more than Malvira. So this doesn't really give us much of an insight as to why Malvira was successful. Then we can say, well, was cooperation different? And as we saw before, cooperation didn't really vary among the community. So they weren't more cooperative around the treatment plant. So that doesn't answer these questions. Then we thought to do a case study analysis of several of these villages. So if we look at Malvira, Amdapur, Borgan, and Naiknagar, we have high success with Malvira, still operating, recovered from a problem, that's awesome. Medium success, so Naiknagar and Borgan, they operated, recovered from a problem, and then failed for different reasons. And then low success, being Amdapur, which operated for 9 months, had a problem, and then never recovered. And one thing that came out of interviews with the Gram Panchayat is that Malvira voted on whether or not to continue supporting the treatment plant. This did not occur in the other villages. And one thing that was also really significant is that the involvement of women at the Gram Panchayat level, they did not allow for surrogate attendance by the women's husbands, which we found in some of the other villages that were not as successful. So the women who were on those boards had to show up and participate and actually create the dynamics that we know lead to some change and community decisions that are different. So the community members had a stronger voice within Malvira. And one thing that I didn't present here, but with our public good games, the cooperation games, one of our interventions was negotiation. And that was the only intervention that we tested that actually increased cooperation over 10 rounds. And what we see here in Malvira is that they are engaging the community to negotiate around the water treatment plant, which could be one of the reasons why they saw more success. So lastly, if we look at the fluoride concentrations, while Malvira was working, it wasn't actually functional. It wasn't treating fluoride. There was no fluoride there. So why was it even there? So only 1 facility was functional, 0 facilities were efficient, and none then are really sustainable in this kind of construct. So most development lists have these communities counted as having success, which is really important. You know, SDG goals will say, yes, all these communities have a treatment plant, they're successful. And we really need to look at dynamic processes, not static ones, to evaluate these. And this is where the research will go post-COVID, hopefully. More operational efficiency indicators are needed for these technologies. They actually don't know when they're not working. And this is what we're doing in the lab and the research that we're doing at the bench. And finally, we need to evaluate why these sites are selected, because contamination is dynamic, it's not static. So we need to look at contamination patterns to make sure we're citing these appropriately. And so it's our belief that the development framework is flawed, but it is fixable, and it's where we hope to go with our research. And just to acknowledge our collaborators on this, and that's all I have. Thank you.
Thanks so much, Dr. Alfredo. That was a very interesting presentation. We already have a comment in Potable, which I'll just read out. It's from Mark Detman. Dr. Alfredo, thanks for sharing the slides and looking forward to your presentation. We are encountering fluoride issues across the Rift Valley in Tanzania and interested in your findings on sustainability of payment to maintain community treatment options.
Yeah, I mean, so I think the payments to increase community success is just one part. I think really what's very interesting about this project and the involvement in this project was looking at using some different methods like the lab and field experiments to probe things like negotiation and you know, a lot of times people put up a poster next to a treatment plant that says who paid. In these villages, when we tested that with the cooperations by saying who gave what during our rounds of cooperative play, that just made everyone stop giving. So some things that are held as kind of standards, I think, in the field would have failed completely if they were implemented in these villages. So looking more and borrowing more from economics, the field of economics, in order to do these studies, I think is really important for water development moving forward.
Thank you. We have another question from Joanne. Why was the 5 years of having the external operator chosen? It seems like a long time compared to the likely lifespan of the equipment. How often did the electroplates need to be changed?
Yeah, well, you know, in theory, these physical structures of these treatment plants should last like 20 years. You know, it shouldn't be even more. Like the physical structure themselves should be around for a long time. So if you're thinking about the lifespan of a treatment plant, you don't want it to be just 5 years. So 5 years was the contract period where a company ran it. After 5 years, it was handed over to the community, and we tracked them for 2 years. And in 2 years after that, they failed. The plates have to be replaced, and this is something that we're testing in the lab. When you ask every different operator, they have a different rule of thumb that they use for replacing the plates. And they even have different ways that they think make them more efficient. And so as a rule of thumb, they like to replace them 6 to 12 months. So once to twice a year, depending on how much water they use and how many times they use it in a day. So they should be able to overcome the replacement of plates once the treatment plant is handed over to the community. It would make no sense to build these if after 5 years they were trash.
Thank you so much. We have a few more questions in Potable, but we're out of time, so I would encourage you to go answer them there. And thank you so much for your presentation.
No problem.
I will now introduce the last speaker for this session. Our next speaker is going to be Monica Lee from Johns Hopkins School of Bloomberg School of Public Health. Welcome, Monica, and you're good to get started.
Thank you. Show me slides. Hi, my name is Monica Lee, and I'll be presenting on Legionella bacteria in premise plumbing supplied by aging potable water infrastructure impacted by prolonged stagnation. A brief introduction on Legionella, which is a gram-negative bacteria that is ubiquitous in water systems. The main ways of exposure of Legionella is through aerosolized droplets that are formed from showers, fountains, humidifiers, and cooling towers. This microorganism in aerosolized droplets can be inhaled into the lungs, which causes human health issues like acute lower respiratory infections. Legionella has a 10% case fatality rate and an even higher rate of 25% in healthcare settings. Currently, Legionella is the leading cause of waterborne illness and has seen a 550% increase of disease incidence since 2001 and approximately 52 to 72,000 cases per year. In the United States, legionellosis, the disease caused by Legionella, is a reportable disease. However, the management of Legionella in water systems occur on an ad hoc basis, and there's no requirements for environmental monitoring. In the most recent report by the National Academy of Sciences, there's a suggestion of 5,000 colony-forming units per 100 milliliters as an action level, warranting serious concern and triggering remediation within non-healthcare building water systems. In response to the COVID-19 pandemic, all across the world, there were temporary shutdowns in buildings to slow the spread of COVID-19. However, this created unintended consequences for our water quality. With the shutdown, buildings had significant reduction in water use in both premise plumbing, which is the plumbing and pipes within a home or building, and engineered water systems like cooling towers and fountains. This created an ideal environment for many water-related problems, particularly with premise plumbing pathogens. The consequence of reduction in water is stagnation, which results in reduced hot water temperatures in hot water systems, loss of free chlorine, and the growth of biofilm, which is the biomass within inner lining of pipes that can house potentially pathogenic bacteria. So our research question asks, what can reduce Legionella growth in an older building impacted by stagnated water? The occupancy level, flushing, heat shock treatments, or even disinfection? These questions are the main focus or takeaways from my presentation today. We were able to explore these questions by looking into an older building within Maryland affected by the COVID-19 shutdown, and really examine what factors can reduce Legionella growth in an older building impacted by stagnant water. This building, which will be referred to as Building A, is older than 50 years, and due to the shutdown had low use from March to December 2020. This building did have partial reoccupancy in January 2021 and back to full reoccupancy in August 2021. The building structure itself has 4 floors, a basement and floors 1, 2, and 3, and 3 risers, which I'll refer to as A, B, and C. We assessed hot water lines at 12 showers, which was the main point of exposure of high interest, since showers have a high aerosolization of water, therefore a high risk of Legionella exposure. We also assessed cold water lines at the entry from the drinking water distribution system in the basement, and also 2 faucets. In order for reoccupancy, the building managers conducted thermal heat shocks and disinfection treatments for Building A. There were 3 thermal heat shock events, August and December 2020 and May 2021, where hot water was heated to above 150 degrees Fahrenheit or 65 degrees Celsius overnight and flushed the next day. There were 2 chlorine dioxide treatments in July and August 2021, where both hot and cold water systems were treated with chlorine dioxide at 2.5 ppm for 12 hours, or parts per million for 12 hours. And there was 1 chlorine treatment in August 2021, where both systems were treated with chlorine at 20 parts per million for 12 hours. In this slide, I will show you a heat map from Building A, specifically looking at the hot water. Before I show you the results, I wanted to set the stage. This figure shows representative Legionella results per 100 milliliters analyzed from a most probable number culture method from December 11th, 2020 to September 14th, 2021 at 12 shower locations. The x-axis shows the sampling dates, and the y-axis shows the shower locations by riser. T0 indicates water collected at time 0, which represents water at the shower outlet. T5 indicates water collected at water collected after a 5-minute flush, which represents water within building pipes. Sampling points that had a value greater than 2,273 indicate that the results were too numerous to count at undiluted samples. The legend here indicates the Legionella concentrations at most probable number, or MPNs per 100 milliliters, by increasing order of magnitude by each shade of red. So starting from the white color, which represents 0, and the darkest red, which represents greater than 10,000 MPNs per 100 milliliters. So here is the data from August 2020 to January 2021. The blue lines indicate treatment conducted at this building, heat shocks in August and December 2021, and partial reoccupancy is noted here as well in January 2021. The heat shocks appear to have reduced Legionella concentrations in hot water initially, but saw regrowth weeks later. Here is the data from January 2021 to June 2021 with partial reoccupancy and water use in the building. A heat shock treatment was conducted in May 2021. The data here shows that there were low levels of Legionella in the winter months, but however, once by spring, numbers start to increase. After the heat shock in May, concentrations did decrease, but saw an immediate increase weeks afterwards. This led leadership to implement additional treatments after the thermal heat shock did not reduce Legionella numbers. Here is the results from July to September 2021. In July and August 2021, there was chlorine dioxide treatments and also a chlorine treatment, which conducted, and it appears to effectively reduce Legionella numbers in the short term. Looking at the heat map overall, it indicated that the heat shock treatments, as well as disinfection treatments, did not effectively reduce Legionella presence long term. Additionally, partial reoccupancy with limited water use did not appear to reduce Legionella presence. It also appears that there is a higher colonization of Legionella in riser A and B compared to C. Overall, the results are very equivocal and shows that Legionella is highly variable throughout the building. We plan to continue sampling over the next year, which will provide more insight to Legionella growth within the system and across seasons. And my main takeaways, Legionella were consistently present and randomly distributed in hot water shower lines. Partial reoccupancy resulting in partial water use did not reduce Legionella within hot water lines. Flushing alone did not remove Legionella from hot and cold water systems. Heat shock was ineffective at long-term reduction of Legionella concentrations in water samples. And lastly, disinfection effectively reduced Legionella in both hot and cold water systems in the short term. There was, however, again, regrowth weeks later. In conclusion, Legionella in pipe systems is a very complex challenge. Additional treatments may be required. We saw that heat shock, slushing, and intermittent disinfection is not effective in long-term reduction of Legionella. So we saw that it really takes a lot of treatment to eradicate Legionella from hot water lines. Flushing alone does not solve the problem, and it does take very extensive treatment to remove biofilm. Currently, there is no federal standards in the United States. However, this is an opportunity to really drive change and protect public health. There are possible solutions for this complex challenge. Additional monitoring is highly recommended. There's also continuous or intermittent disinfection in your water systems, and also point of use remediation, such as changing out your shower heads with filtered shower heads. Bottom line, every building needs a comprehensive water management plan. It needs to be both developed and implemented. And this is to ensure the safety of all building occupants. Lastly, I'd like to acknowledge the Johns Hopkins University Stantec Alliance Laboratory and also my funding sources. Thank you for listening to my presentation, and I'll open up to questions.
Thank you. I'll be watching the chat in Potable for questions. Looks like we already have one. It's from Joanne. She wants to know, was there any data on how often each of the showers were used in each of the months?
So we currently do not have the water usage data, but that's something that we were keeping in mind also. So once that data is available, we'll be able to incorporate that.
Thank you. I was curious to know how you chose the flushing time. Like, was there 5 minutes, a specific reason for that?
I think we just went at the beginning of our collection, it was very ad hoc. So we kind of went with the best possible time, which was 5 minutes. So it was more of a response to when we were sampling earlier in our project.
Thank you. It looked like at the beginning in, I think, August, when you first had data, the flushing was successful because there was a high decrease in Legionella. But afterwards, flushing did not have much of an effect. Why do you think that change occurred?
Multiple reasons. Again, it's very short term. It might have just flushed out the Legionella that was in the water, but not everything that was in the biofilm that was currently in those pipes. There's also possible seeding from the water drinking water distribution system that also reintroduced the microbes back into the system.
That makes sense. Thank you. I want to remind folks that questions should go in the chat box in the session page from Potable. Oh, we have one more question from Kellogg. He's asking, what are long-term solutions?
Long-term solutions, like I said previously in my slide here, again, we can have continuous or intermittent disinfection in your water systems. Another long-term solution is, it might be very expensive, but to replace all the piping and plumbing in the building, but that might be more cost, that cost has a higher cost and energy to it.
Thank you. Well, we can wrap up this presentation. Thank you for your time, Monica. That was a wonderful presentation. We have a couple of, oh, never mind. There's one more question that we can address before we head out. It's from Catherine. She's asking, do you see any unintended consequences with the solutions? What are the risk trade-offs?
Yeah, so again, with continuous and intermittent disinfections, you always have to check for disinfection byproducts. That's an unintended consequence. Also, you said, what are the risk trade-offs? Again, cost and energy too. Cost a lot of time and effort and money to place these kind of solutions into water systems.
Thank you. And that puts us right on time. I will remind everyone that the chat box in Potable should remain open. So if there's more questions, they can go there, and presenters are encouraged to go and respond to comments and questions there. With that, I will move to closing announcements and just remind everyone that to return for poster sessions at 2:45, and also that another reminder about the networking event this afternoon on Remo at 3:30. With that, I'll close this session and thank you all for your attention and time.